great to finally start the series. Dalhousie University operates in the unceded territory of the Mi'kmaq, Wolastoqey, and Wesco-Mugode peoples. These sovereign nations hold inherent rights as the original peoples of these lands, and we each carry collective obligations under the Peace and Friendship Treaties. Section 35 of the Constitution Act 1982 recognizes and affirms Aboriginal treaty and treaty rights in Canada. We also recognize that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched that part of Mi'kma'ki known as Nova Scotia for over 400 years. My name is Matthew Herder. I'm a professor in law and medicine and the associate director of the Health Justice Institute, and I'm thrilled to finally open this year's seminar series, welcoming our first guest, Dr. Martha Paynter. Before I introduce her, I want to say a few words about the series this year, our theme, where we're going, and what each seminar sort of looks like for those of you who are new to the series, although it's great to see some familiar faces too. So the theme this year is around community. What is community? What is the relationship between health justice and community? How do we, in some cases as academics, engage with communities? How can we learn and be informed by and led by communities in our pursuit of health justice in various domains of work? That's a theme that is really being developed and led by in a variety of activities at the Institute this year, led by our new director, Professor Sheila Wildman, who stepped into that role on July 1st. She's actually going to close the seminar series this year in March and talk about that broader suite of activities and the theme of community and health justice, and we hope you'll join us then, as well as every seminar between now and then. I won't steal her thunder and tell you more about some of the new initiatives that we're hoping to launch in the coming months, but it's a really exciting time for us at Health Justice here in the law school and all of the actors and community and other faculties at the university that we hold dear. Each seminar, logistically speaking, runs around 40 or 50 minutes for the speaker, followed by a moderated question and answer period. We finish around 1:25. I think there's a class that comes in right after, sometimes a little bit earlier, but just keep that kind of time frame in mind. Okay, without further ado, let me introduce our first speaker in the series this year. Dr. Martha Paynter has worked to advance abortion access in Canada for over 20 years. A writer, nurse, and public scholar, she is recognized internationally for her expertise at the nexus of reproductive justice and prisoner health. She's an associate professor at the University of New Brunswick, Faculty of Nursing, where her research addresses the health rights of people experiencing incarceration, as well as sexual and reproductive health care in Canada and around the world. She's the lead author of Lawless, a brand new book you can see on the screen. It's just outside the door. There are copies as well. There's a book launch tonight, actually at the Bus Stop Theatre, if I'm not mistaken, at 5:30. As well as an earlier book, Abortion to Abolition, also sitting outside, Reproductive Health and Justice in Canada, published by Fernwood as well. She's published extensively in magazines like Chatelaine and many different scientific journals. Dr. Paynter is a keen advocate for increasing the influence of women and gender-diverse people in news media and participates regularly in interviews with national and international print, radio, and TV press. She values and fosters collaborations with community organizations and lived experience experts in reproductive health and prison justice. Dr. Paynter is a recipient of the 150th Anniversary Medal from the Senate of Canada for her volunteer service to the country in 2017, and the King Charles III Coronation Medal for service to the nursing profession this year, 2025. In my view, Dr. Paynter is the rare scholar who can say precisely and concisely exactly what she means in the moment, often in the face of adversity. A skill that is actually quite rare in the academic community, but required given the focus of her work on access to abortion, prison health, and reproductive justice more broadly. Please join me in welcoming Dr. Paynter to open our series this year.
It's a pleasure to be here. Thank you, Matthew, for the introduction. I know a lot of you. I actually want to acknowledge Dr. Sharon Batt, who gave me my first job like 25 years ago in sexual health and ethics. And So it's been a road. I wanted to start this afternoon by reading from the book, and just briefly, and then get into the presentation. And yeah, so let's do it. Okay. Canada is the only country in the world in which abortion is completely decriminalized. This fact is remarkable, powerful, and enduring. In recent years, many countries have made significant progress towards partial and even widespread decriminalization. In 2024, France incorporated into its federal constitution the right to abortion to 16 weeks. In 2022, Colombia decriminalized to 25 weeks. In 2020, New Zealand decriminalized to 20. There are many other examples. Meanwhile, the United States has notoriously lost ground, and in the tumult of these changes worldwide, public conversations about and understanding of abortion have changed. As a clinician and researcher in this area, I see how the public is increasingly curious about what abortion is, brazen about asking for answers, and determined to see remove the remaining obstacles blocking access to care. Even after 37 years of sustained, complete decriminalization, the on-the-ground reality of abortion in Canada is uneven and unclear. The anti-choice lobby is robust, well-funded, and persistent. Competing with this industry is laborious, and I often feel like factual publications are the needle in the haystack. This book is a needle then, but hopefully a big one. This book is intended for readers with an interest in clear, matter-of-fact, approachable information about how abortion works in a contemporary context of complete decriminalization, as well as guidance on important focal areas to improve access. Activists and champions for abortion may come away with stronger convictions and precise targets for new dimensions of advocacy. Community organizations will recognize persistent barriers for clients and learn practical navigation strategies. Educators and students of law, women's and gender studies, political science, history, sociology can use this book to develop different perspectives on the complexity of a topic significant to each discipline. Health professionals can learn about an undertaught, stigmatized, and yet essential service in ways that may change their practice. Policymakers should read this book to see what matters most now and where they can be most impactful. Journalists should read this book to get the facts and disseminate them widely. Youth will learn what abortion is and the extent to which their privacy and autonomy are protected when seeking care. Parents, likewise, can read it to understand the regulatory and service landscape youth face when seeking sexual and reproductive services, and to empower their children to speak knowledgeably and compassionately. My intention with this book is to introduce abortion to wide audiences in language and approaches that are pragmatic and positive. I'm extremely proud and protective of Canada's position on abortion and dedicated to its perpetual improvement. The aim of this book is to explain how far we have come in recent years through the relentless efforts of activists and providers, and where we need to go from here. The title, Lawless, honors the rebellious energy of Canada's extraordinary position as the lone country globally with complete decrim. But Canada is actually not lawless at all. Layers of laws and regulations at the federal, provincial, territorial, even municipal levels impact abortion, even if there is no one abortion law per se. This book tells the story of that complexity, while also drawing attention to the ways in which abortion access can be improved outside of legal frameworks, through research evidence, health professional leadership, frontline ingenuity, and the banal act of talking about abortion as a norm. Okay, so to start this presentation, I want to acknowledge that I work in Fredericton, which is the unceded territory of the Wolastoqey, and these are photos of the Wolastoq River, where I now live. So let's just go back very, very, very far to situate this. Many of you are lawyers and law scholars and know all this, but some of you are not. So in 1892, that was the moment that we had this first criminal code federally which criminalized abortion, as well as a bunch of other very sexed and gendered things, sex work, contraception, etc. And that kind of was what the status quo was until 1969, with what's known as the Omnibus Bill, the first Trudeau era, which decriminalized, it's an omnibus, so it did a bunch of things at once: divorce, homosexuality, contraception, and partially abortion. So that was a really important moment, but what remained in the criminal code, section 251, continued to require what were known as therapeutic abortion committees. So the Therapeutic Abortion Committee was a group of 3 physicians who you would have to seek their approval before you had an abortion, and you had to have the abortion in an appropriate designated hospital. And those were the limitations. And it seems, well, how bad is that? And it was really very bad, because it would take a very long time to find how to get to the TAC. Each TAC had its own criteria. Each member of the TAC could make up their own, say they didn't want to do it past 12 weeks, or say they didn't want to do it for XYZ indication. It was up to them. And from going to the TAC to then getting the procedure, weeks and weeks and weeks would go by. And so this really was a very inadequate solution to the problem of inadequate access to abortion. Okay, so at this point, we start the Henry Morgentaler era. I'm sure most of you know the story of Dr. Henry Morgentaler. So 1969, Omnibus Bill, he immediately sees that this will not be sufficient and opens a clinic in Montreal. Dr. Henry Morgentaler was a Holocaust survivor. He was working as a family physician. He had a real humanist ethos, and he basically just was unwilling to see people suffer. Very soon after this, he was arrested for providing abortions outside of the legal framework. And he was incarcerated. He spent 10 months in jail. He had a heart attack in jail. And he was tried 3 times. No jury would convict him, right? Like, there was just this underlying understanding that what he was doing was right. Finally, things escalate into the famous 1988 R.V. Morgentaler decision, where we have this result that very anomalously at the time and ever after results in abortion being completely decriminalized and recognized as a health service. Stemming from this Section 7 argument, right? And so meanwhile, all these years are going by, Henry's being tried. Meanwhile, Canada passes the Constitution and has this charter suddenly, as well as the Canada Health Act. So these pieces of federal legislation in the 80s set the stage for the eventual Morgentaler decision. Section 2 of the charter, this right to life, liberty, and security of the person. Any restriction on abortion is a violation of that right to govern your body. And the Canada Health Act, which we've only had Medicare now it's 41 years, that ensured that the care was also free. So we go from quite a restrictive and protracted and complex period to suddenly all abortion is legal and free. And there was some resistance and so on and so forth, and I won't go into all of that. But we end up with this context where there's no law governing abortion anymore. There's no gestational limits in law. This is one of the most important parts of the Canadian uniqueness. We also don't have parental consent requirements. We don't have waiting periods. We don't have required counseling. You're not required to see the ultrasound of the fetus before you make your decision. it's healthcare, and you should do it in a way that is appropriate according to your healthcare needs and according to how the healthcare provider is, of course, regulated. Abortion is really, really common and safe in Canada. There are about 100,000 abortions a year. 1 in 3 of us with a uterus is going to have one in our lifetimes. Abortion is the most common outpatient procedure there is. And yet, we continue to treat it as this really anomalous thing. And from 1988 until 2017, we continue to have very serious barriers to access. So only physicians were authorized to provide abortion services. And these physicians tended to work in clinics in very large urban centers. There actually were only about 100 abortion clinics in the whole country, half of which were in Quebec because of Morgenthaler's leadership. It was very common to require a referral. So, okay, it's not a TAC, but you have to go to one physician, get their authorization, then you basically have to go to another. So it's 2/3 of a TAC. And this was the big thing, that 96% of abortion was procedural, what we used to call surgical. And we're really working on changing that language because there is no cutting, and procedural is more appropriate. Mifepristone wasn't available. So this map kind of shows you the dispersion. In 1988, so the same year of the Morgenthaler decision, we have mifepristone launched in France. So mifepristone, which is the first little tablet, is remarkably effective at ending the pregnancy. When taken in combination with misoprostol, so those are the little hexagons, misoprostol then works to induce cramping and expel the tissue. So those two things combined result in a very effective abortion experience. Yet, it wasn't until 2015 that this medication regimen was approved by Health Canada. And we didn't get it on the shelves until 2017. That part is a little bit normal, but. When we first had mifepristone available, it cost $350. And it also was introduced with a whole lot of regulatory restrictions. So basically, Health Canada said, it's okay that we approve this medication if it's prescribed by physicians, the physician observes you taking this medication, the physician does a course first, they register, the pharmacy that distributes it registers. And also, of course, you needed to have an ultrasound. So with all of these requirements, the people who were doing medication abortion were the exact same people who were doing procedural abortion. And that really wasn't making much of a difference whatsoever in terms of access. And it had been to improve access that activists had been lobbying for ages to try to get this Health Canada approval. The way it works in Canada, you can't, like I can't as Martha, go and apply to the to Health Canada and say, listen, there's this extremely effective drug that's been in use in Europe for 3 decades. I think we should have it here. I can't do that. A province can't say, listen, we've heard about this. I think it would really improve things. You know, we've got this 5-hour drive to get to Halifax from Sydney. I think this would help. We can't submit that. The only body that can submit is the pharmaceutical company themselves. And we are not really that great of a market, right? We're a small country in terms of population. And mifepristone, like, you're going to take it once. It's not labetalol. You're not taking it every day. This is not a very lucrative endeavor to go through all the expense of the Health Canada approval when it's for this pill that is a tiny little country and people are only going to take it one time, maybe 3-4 times, right? So it took a long time. And then when we got it, it was all these restrictions. So we worked and showed Health Canada that there was evidence that this was not a good idea. And globally, there was plenty of evidence that we didn't need any of these regulations. And between 2017, when it first hit the shelves, and 2019, we got it completely deregulated. One piece after another. Physicians do not need to do a special course for this medication. Every time a new medication comes out, physicians don't do a special course. Obviously, they have to learn about it so that they're competent, but requiring that you register and pay and go through this extensive training program, no, that's gone. Nurse practitioners should be able to prescribe. There's no reason you need an ultrasound as long as you're sure of your dates and you're not concerned about ectopic pregnancy, et cetera, et cetera, et cetera. So we picked away. It's actually totally wrong for physicians to be dispensing the medication. Like, physicians don't do that. Pharmacists do that. We have that separation for safety reasons, et cetera. So we pick away, and then it's a completely normal prescription. There's no difference between getting a mifepristone prescription and penicillin. So this happens. And basically, the story is you go to the prescriber, who can be a family doc, they can be a nurse practitioner, or I guess they could be an OBGYN. You get the prescription, you go to Shoppers, you get the medication, you go home, you take the medication, the first pill. Nothing really happens, but what it's doing hormonally is stopping the pregnancy. It's done. And you can't undo it. It's done. And then the next day, you take the misoprostol, it dissolves, and it brings on cramps, which cause the tissue to leave your body. It's painful. It's a miscarriage at your house. That's what's happening. So this is, starting to happen. People are getting used to prescribing this. We're seeing very, very quickly the number of prescribers are ballooning. So we go from having X number of abortion providers in 2017 to 4 times as many in 2019, and et cetera, et cetera. So we've seen exponential expansion of the abortion workforce. We also had a very extreme experience with COVID. All healthcare providers did in different ways, but we experienced 2 things that were actually very good for access. Maybe 3 things. The first was that this government, and many of the provincial governments, described abortion as essential care. There would be no closing of the OR. There would be no, you're getting your care. You have COVID, you're getting your care. So that really changed the conversation about abortion. Then we had, people were starting to do telemedicine for all kinds of things, and people started getting used to doing telemedicine for abortion. So instead of coming to the clinic, you just talk over the phone and talk just like I just told you. What would happen, what to expect, have some Advil around, have a hot water bottle. That's counseling that we can do over the phone. So we started doing that. And another thing that happened, which maybe I can get into later, but we really just expanded our gestational duration capacities. There's no law limiting gestational capacity, but most abortion in Canada is in the first trimester. Having an abortion in the second and the third is very, very rare. So we don't have a lot of places where you can get it done. And we used to send people regularly to Colorado, to Maryland. And Nova Scotia would pay for it. And we'd send them, and they'd have their second or third trimester procedure and come home. And with COVID, we all remember, you needed a vaccine passport to get on a plane, right? So the patients who are needing later gestational care they have complex lives. They have got a lot of hardship happening. And they do not have a passport, and they definitely don't have a vaccine passport. They're not the people who can hop on a plane tomorrow. And so we, as providers across the country, were kind of like, what can we do? I guess we could just get better at this. And across the country, So PEI, PEI was doing procedures to 12 weeks, and then they were like, well, it's not that different to do 14. And if we get this instrument and that, we could do 16. And now they now do to 20. And we all did that across the country. A little bit more, a little bit more, a little bit more. So maybe you have to go to Montreal, but you don't have to go to Colorado. Anyway, that was COVID for us. And this transformation in what abortion was, that it's this pill that you take at home, it decoupled abortion from the clinic. Our clinic here at the VG, it's extremely safe. It always has been. It's on the 5th floor. You're going into the Dixon building. Nobody knows what you're going in there for. It could be anything. So it's very safe. We're not having our patients harassed. But there are a lot of places where that does happen. And providers, when we first introduced MIFI, were worried about a lot of harassment. And then they just stopped, because what is the anti-choice lobby going to do? Picket every single family practice? Every single place in the entire country that this prescription should be? Every shopper's? So it just decoupled that danger. And it made our patients safer, and it made us safer too. So then what's happened very recently, of course, with the fall of Roe in June 2022, we've had this yet another wave of improvements. We've continued to work on that gestational duration work. Now we've set up this network across the country. We're all working together, a mentorship network, to ensure that we have people trained to do this later gestational care, that ensure that we're all connected. Okay, you don't have any space in your clinic for the next month, so who can take? We're communicating. We're also working on expanded scope in lots of different ways. So we had the nurse practitioners start prescribing. That was really great. We have midwives prescribing in some places. That's, province by province, right? That's how we regulate healthcare. So Quebec, we have some pilots where midwives are prescribing, Ontario. And we're doing other things, right? We're working on, pharmacists prescribing of birth control. So if the pharmacists are prescribing the birth control, you don't have to go to the GP for that. And so the GP can do more, et cetera, right? We're all like picking off our little bits. And we've introduced abortion as a very normal part of our curricula. If you're going to nursing school now, the Canadian Association of Schools of Nursing has competencies in abortion care that you have to graduate with. It's in med school. It's in pharmacy school, social work school. Normalizing this. And then a bigger project, a really forever project, is for us to work on the quality of our care. Gender inclusion, reconciliation, culturally safe work. That we kind of now, we're thinking about it because we were so worried about, safety and this and access. But now we can really sit and think, like, the name of our clinic sucks, let's change it. This form sucks, let's change it. We have no idea how to do contraceptive counseling with Indigenous people who have survived a legacy of forced sterilization. How are we going to do that? Let's figure it out. So we now have the capacity to think very differently about what this even is, what this work is, what reproductive justice is. Okay, but that doesn't mean that we don't have barriers. So this is the shift in the talk where I talk about where we still have work to do. The first is belief-based denial of care. Who saw that global piece this week about Cherise Basque? Anybody? Mary? So we're still dealing with this situation where patients are worried about, justifiably so, that when they go to a provider, given that any prescriber could theoretically prescribe them medication abortion, how do they know that their prescriber is a good one of the good guys? There's no way to know, right? We're not hanging out shingles on our community health centers or our family practices saying, this is a safe place to ask for medication abortion. Maybe we should, but we're not doing that. So this case with Cherise seeking care post-abortion at St. Martha's, famous St. Martha's in Antigonish, and being turned away. How in 2025 are we still in this situation where hospitals, buildings, think they have Section 2 rights to freedom of religion. So this is persisting. And this is certainly a matter of our code of ethics. You can't abandon a patient. It's a violation of our code. So we have this inherent friction. And we should be able to report this to the college. There should be a complaint. There should be disciplinary consequences. But of course, people are, they're not all of them are Cherise Basque. They're afraid to complain about the poor care that they're given. And so this remains a problem. So we have to keep on working on that. And what we're doing right now is reframing this from conscientious objection, the way we used to talk about it. And conscientious objection, right, of course, is that refusal to participate in war. And reframing this as a belief-based denial of care. This is a different profession. These are different consequences. You are harming another person. And you have a vow to not do that. So we're continuing to talk about this. There's no reason why, for example, at St. Martha's, the mission assurance agreement that St. Martha's and the NSH and Department of Health, they have this tripartite agreement that allows St. Martha's to just not do any care in violation of their Catholic faith. Like, we just can't have that agreement anymore. It's from 1996, it's over, right? But we have to get there. It might take a lawsuit. Crisis pregnancy centers, or we're starting to call them unregulated pregnancy centers, or just plain fake clinics, right? So there are hundreds and hundreds more of these in North America than there are of actual abortion clinics. These are outfits that are run by religious organizations that have charitable status and get tons of money flowing in and have money to burn on billboards and fancy Google algorithms. If you Google abortion place name, you are going to get the closest crisis pregnancy center. So there are things that we can be doing to deal with this. We can try to close that loop, try to revoke their charitable status. There was some work on that at kind of the end of the Trudeau era, the second Trudeau era. We can try, again, through our colleges, our public regulators, try to address the fraud. Basically, these people are presenting themselves as clinicians, and they are not. These are not accredited clinical places. We could do some work there. We could also do some work advertising our own truthful, real services. I'll get to that. There is, how do I talk about this? So bubble zone laws were a solution since the 90s to the threat that we were experiencing as abortion care providers. 1994 to 1997, there were a series of extreme acts of violence. The firebombing of the Morgentaler Clinic in Toronto, sniper attacks on providers, Manitoba, BC. Nobody died, but there was obviously harm, and it was terror. The point of it was terror, right? And the legacy of that has lived on for a long time. People who endured that era remain conscious of what their colleagues went through and what they themselves felt in terms of fear at the time. So we had these bubble zone laws that activists push for and that we have achieved in lots of places that would prevent protesters from coming anywhere. I mean, obviously it's illegal to be a sniper, but this would prevent the protests around the clinics. But what we're seeing now is that work that we did is being leveraged against progressive work. It's being expanded. Okay, now you can't protest in front of health care institutions of any type. Now you can't protest in front of mosques and synagogues. And we're not comfortable with our work to protect patients from harm being leveraged against our intersecting work for Palestinian liberation, for democratic participation. So we're in this weird moment now where we don't really know what to do with this. It's not super clear. It's a problem. We do have bubble zone law here in Nova Scotia. Huge issue. What are we going to do with this? Mis and disinformation on social media, on US news, on Canadian news. There's so much money in mis and disinformation, and we are not investing at the same level with the facts. We also aren't very savvy. Like, it's not very cool if Public Health Nova Scotia puts out an ad about sexual health. It's just not, it doesn't get the same audience. So we're really dealing with a lot of consequences of that. One of the most egregious is youth not understanding their rights in Canada. There's no special rules about getting sexual and reproductive health care, including abortion. If you have the capacity to consent to health care as a youth, you have the capacity to consent to health care. It doesn't matter if it's the flu vaccine, that penicillin prescription. Abortion is not special. You don't need special permission. But we have so much garbage that youth don't know that. So we really have to work on that. We really have to work on telling people, like, the US situation is not our situation. This is not our situation. And we also have to keep up with rapid change. Things have just, so first we get MIFI. People don't know what MIFI is. People don't know about medication abortion. Nursing faculty that I work with have never heard of it. They think it's Plan B. People think it's Plan B. So we need to work on that very basic understanding. This is a thing. Now, we do have this is a good thing. We have laws in Canada that you can't advertise prescription medication. I mean, there's lots of cheating on that law, but that's a law here. So what are we going to do? We need to advertise medication abortion as a process. We need to do it. And we also, it is challenging to keep up with rapid change, right? So that example I gave you about PEI. A lot of people think that they don't have abortion on PEI. Like, we did litigate, we got it. It opened in 2017. It's beautiful, it's a palace. And they went from 12 weeks to 14 to 16 to 20. Does anybody know that? How are you going to keep up with that? It's just a change that we made because we felt like doing it. How are we going to get that information out? Abortion clinics don't have money. We're just publicly funded. We don't have advertising dollars. And yeah, some people are still afraid to be like, by the way, here's my shingle. Come here, I do to 20 weeks. We continue to exclude people without a Medicare card from this free care. We did this really incredible work back in 2017 to make medication abortion, which, like all the medications you go to Shoppers Counter and pick up, you have to pay for, right? That was the way it worked. It was an outpatient prescription. You go, maybe you have Blue Cross or whatever. And we worked on it and we made the governments pay for it. Saskatchewan was the last to fall in line, but it happened everywhere. And so both procedural and medication abortion are completely free if you have that Medicare card. And we have, I mean, I know we've done a lot of recent things, but in general, we have a lot of international students and temporary foreign workers and people who are here without papers more generally, and they can't get this care. It's $3,000 for an abortion procedure in a hospital. If you get your abortion pill prescribed in a hospital, it's basically $2,000. So, because of all the physician fees and this, we have to make the chart for you, blah, blah, blah. It's expensive. We have got to deal with this because the consequences of unintended pregnancy for this population, and not even getting into exposure to sexual violence, the different risks that they're facing, consequences for their employment, like we just can't be doing this. It's not that many people who will need this support, at the bare minimum, pregnancy-related care has got to be free. And of course, our failed plot to get universal contraception for everyone, right? We were so close last year. And it's so disappointing that in the end, we're at a place where only BC and Manitoba, who started it on their own without the feds holding their hand, and coming, Yukon and PEI, they get to have free contraception and we don't. Like the data out of BC, LARC, long-acting reversible contraception, so those expensive IUDs, prescriptions went up like 100% when we made contraception free. There are people who are not having their needs met because a sex and gendered service is unattainable for them. And the consequences of having to go through with an unintended pregnancy are so dire. So that's, we have to keep up that fight relentlessly. And so we have to do all that, and we really have to advertise abortion. We have to talk about abortion. We have to be, it's, like I said, it's extremely common. And we're still so stuck in stigma about it. We need to talk about it. We do need some billboards, some bus ads, yeah, we need those. And we need some savvy social media. And then we will get to where we need to go. So to close, because I want to have lots of time for questions, there's no abortion law in Canada. But there are many, many layers of many different pieces, from bubble zone legislation to laws against direct-to-consumer advertising to youth capacity consent. There's a whole bunch of things going on with abortion regulation. And the priority right now is to advance education and to destigmatize and to make sure people know the pathways to care that we have worked so hard, especially in the last 10 years, to open up. That's it.
We have lots of time for questions, as Dr. Paynter said, so I'll try and keep the list if a lot of things go up.
Are you doing this or am I doing this? I have a better view.
Sure.
Hi, thanks for the presentation. Someone who does health education on this campus, in terms of advertising and sharing information, best practice advice around that, I welcome.
So here in Nova Scotia, it's actually very simple. We launched a model in 2018, the complete centralized self-referral model. So like I put it in my syllabus, 1-833-352-0719. It's very simple here. You call one number, you can get care anywhere in the province. And we're moving to that model in New Brunswick. It's already been announced. We're working on it. We're moving to that model in Manitoba. It's not necessarily possible in a giant place like Ontario, but because you have to know things like, Kat's on vacation for a month, so don't send her patients. Like the minutia you have to have is really intense, but it's really simple here. So that's what I would recommend. Like, make sure people know where the Rose Clinic is. They do telemedicine. You don't have to go there. You just call the number. You will be sorted. And we're working on that, across the country to reduce those referral hiccups. Kaylee.
I'm wondering if we can talk a little bit maybe about the way in which political priorities and the money part of it is also a limiting factor. And so I'm thinking about specifically in Nova Scotia we have trained midwives who aren't working in clinical practice because there's not actually a place for them to, there's not actually a way or a model or a place for them to work. And so we're unable to increase the capacity. Or the way in which we're not how we're seeing a situation where there's money for free contraception, but then the province is well, actually, we're not going to try and access that money, essentially, in Nova Scotia. and how maybe some of that is like also has an ideological underpinning, that it's not just about like we're low on cash, but it's like, you know, we're low on cash for
Women.
and for abortion, for gender affirming care, for the kinds of care that women need, that, or like women
And gender, yeah, of course.
people need, that we maybe don't agree with. Because like, you know, BC and Manitoba, not gonna like, it's like, those are NDP governments who have like long stood for access. And so it's not surprising to me that that's where things got going. And it's also not surprising to me that here, even though the money's on the, like, even when the money was on the table from the feds, the province was like, I don't know that we want that money.
And the money is technically back on. They just have to have the conversation. There was a period where we weren't really sure what Carney was going to do, but it's back on. Yeah, I mean, it's all connected, and there is such devaluation of the healthcare needs of women and gender diverse people. But we also see complexity, right? So in Quebec, for example, Quebec had the lowest uptake of medication abortion in the country. So in New Brunswick, it went from, remember I said it was like 4% medication, and we were using methotrexate. So 4% medication, and then it goes very quickly. Right now, it's 72% of abortion in New Brunswick is medication. Okay, in Quebec, 4%, 11%. So what was going on there? The physicians weren't going to let non-surgical abortion providers become prescribers, let alone nurse practitioners, let alone, okay? So this was territorialness. Yeah, so there's a lot of complexity here, and you know, you talk about midwifery, there's a lot of complexity, turf wars there. A lot of different players. I mean, an overarching theme of not actually prioritizing the health of this population, for sure. But there can be different levers. And so what we did see in Quebec is after Roe fell, then they were like, oh, wait, like we don't want to seem regressive. Never mind. Anybody can prescribe it, including midwives. So then they go the next step, right? And we do see that. We saw that with PEI, right? We're not going to have abortion. We're not going to have abortion. We're going to have the best clinic and the best services ever. And so there is some of that. We do see remarkable innovation when it like has been really this protracted fight, but it's complex. I mean, I think it's very important to keep up this fight in a really interconnected way because it is very connected. Yeah. Who's the next question? Oh, sorry. Yes.
Being frank, I am myself trans, and that means in many cases I can have difficulty accessing certain kinds of medical care, just nature of my situation. Prescribers who don't have a whole lot of training in gender issues, who don't have a lot of training in sensitivity, and I worry that a person like me or someone very much not in the same situation might have similar kinds of issues, but if you're seeking an abortion, which is an intensely personal, private, and difficult decision for a person to make, might be dealing with extra hurdles that they should never have to while making that intensely private and personal decision. And I'm worried about access, not just for women, but also for women, but people who may not appear to be women and still need those services.
Yeah, so I think, again, going back to this advertising idea, that we do all the very basic work, and we have seen that across the country. So here at our clinic here, which had been called the Nova Scotia Women's Choice Clinic, we as a staff unanimously and collectively changed the name to the Reproductive Options and Services Clinic after our so the Rose Clinic, after our medical director, Jacques Desrosiers, and it took 3 years of fighting to get the executive of NS Health to agree to that. So I know it seems like, well, that's just one stupid thing, so you change the name, whatever. Like, that's not trans-inclusive care. It was a thing, and it was a whole process, and we're doing that across the country. There are these efforts. Ellen Weed is an extremely well-known and well-respected medication abortion innovator, and her clinic used to be called Willow Women's Clinic, and now it's just Willow. Like, it's a small thing, but it's a first thing. And, there is this friction in all of this care, gender-affirming care, abortion care. You democratize it, and that's awesome for access. But that does mean that every person who's doing it is not doing as much, and they might not be as adept. And that's a trade-off. And we're actually studying that. What are people's preferences? Do you want to go to a provider who does 40 a day, whatever it is? Or do you want to go to the provider who lives on your street? And she's never done this before, but she's really willing to try. But she might not be very good, but she's really willing to try. What do you want more? And we don't really know the answer, but we're exploring this because that is a part of this in so many different ways. Yeah, thank you for that question. Yes?
For people who are not, directly involved professionally in, abortion, but want to support access, knowledge, what would you recommend in terms of volunteering, charity, other ways to support?
I think, it goes a long way to recognize what we each have in terms of have you asked your family doctor if she prescribes medication abortion? Just so you know that she's a safe person you could send somebody to. And if she has never been asked that before, it's a light bulb moment. Because everybody has never been asked that before at some point, right? And so those individual relational conversations are just to say to your friends, like, oh my God, I went to this talk and I learned the 1-833 number. We should all just have it in our phones in case anybody needs it. Like, these little things actually do really matter, because the way we get information about this kind of care is very, not like familial, but it's familiar, right? We do a lot of information gathering in very close circles. And don't underestimate the value of just knowing what you're talking about for this very stigmatized care. And yeah, I'd start there. Matthew.
So I'm really interested in this idea about advertising.
What's the number?
1-833-352-0719.
352-0719.
Great.
Advertising is like a part of the strategy is to push back. And so I don't think the ban on direct-to-consumer advertising is a problem at all, right? Because that Health Canada is rather a loophole into that. You could drive a truck through as long as you mention the indication and the same thing, you're fine. So, but my worry would be more about, which you also spoke about, the level of support for anti-choice, anti-abortion campaigns, and how if you were to get some resources to embark on advertising to inform, it's just going to precipitate more misinformation, more pushback on some of the things you talked in the book around, like how very valid concerns about intimate partner violence are being co-opted to sort of try and assign more value to the fetus. And these very clever moves, whether it's the crisis centers you talked about or other moves that are presumably being supported by a very well-resourced lobby. So I guess I'm just wondering if that would just ratchet things up and it would become even harder.
I don't think so, but I mean, I'm just intuitively saying that.
Or have you thought more about when you say advertising, what do you mean?
I kind of mean everything, right? Like, so it's things as simple as, like in New Brunswick, where I'm currently living, when you Google, that the first thing that comes up on the web page for the abortion clinic in Moncton City, it shouldn't be, here are your 3 options: adoption, continuing your pregnancy, scroll, abortion. I Googled the abortion clinic. That has got to be the front of the thing, right? And they made that change. So sometimes I'm talking about actually quite small changes and that really improve our information sharing potential and recognizing where all these anachronisms like that, that's the clinic's webpage. No one in that clinic would ever say such a thing, right? But they didn't make the webpage. And so really looking at where are people getting information, where would be a useful place to put this information? Maybe it is a bus ad. Maybe it's a billboard that will definitely get graffitied, but let's try. Yes.
You said you worked in sexual reproductive health as part of abortion as well. I was wondering, has there been a lot of pushback to improving the education in schools, like grade schools, and what is the uptake in outside of nursing education, social work education, what is the uptake on the ground for children?
For children, yeah.
Understand what their rights are, and like with the youth, capacity to consent to care, things like that.
That again, so that's education is provincial, so it varies very heavily. And there are like wild attacks on sex ed, particularly in Alberta. But it very much varies by province. And there are some efforts, but it's very motley. Yeah, it certainly is a good idea. But one of the issues is, we're in health, and that's this silo, and not that we're not employed there. And actually, nurses are no longer employed in schools, almost ever. Did you have a follow-up question?
Yeah, so in your opinion, like how could that be improved? Like, is it like collaboration between education departments and health departments, or is it like creating programs on the ground? Like how can we, like from the top down, improve those education systems?
Action Canada for Sexual Health and Rights, so our national sexual health organization, does have like the best caliber in sex ed materials that are very evidence-based and collaboratively produced. So from an incredibly top-down perspective, we could say everybody should be using Action Canada's stuff, and that it be some kind of curriculum requirement within the Department of Education that they use this material. Like that would be the most efficient top-down method that I could imagine. We have people who are extremely skilled pedagogically and to do this education well. Like releasing me into a junior high classroom is probably not a good idea. So I think there has to be like some delegation or respect for junior high educators having the ability to take the best stuff out there and use it in their classrooms the way they would. Oh, yes, Anne.
Thanks for your talk. It really reminds me of the challenges working in HIV prevention around PrEP, prophylaxis, and so much.
Maybe you could just briefly tell people what that is.
Pre-exposure prophylaxis is a daily pill, now in injectable form, you can take twice a year even, that will prevent HIV transmission from happening if you're exposed. And there's so much stigma around that particular medication, and so much energy and resources go from the nonprofit sector, you mentioned, to put out the messages. Did you know there's a daily pill now? And I think it's the same kind of thing that has to happen with mifepristone, which I can't pronounce. But we
just say Miffy.
Miffy. So it's just really annoying, because I also teach about the nonprofit sector, how much of this essential service, which is awareness raising, is downloaded to nonprofits.
Yeah.
And all of that public messaging that you're talking about is super expensive.
Mm-hmm. It is.
Billboards,
it is.
It's a big job. We, at Sexual Health Nova Scotia, we worked on a project called Sugar. Have you heard of that?
Mm-hmm.
Yeah, so Sugar is basically a website as well as a worm line. So it's not a pure hotline because they're not adequately funded, but it's basically an inventory of healthcare providers in Nova Scotia who are sexual, gender, and reproductive health friendly. So ones that can be who have put up the placard on their door and say, I am open to queer health, sexual health, HIV prevention, harm reduction. So, but again, they only got 1 year of funding to do that work, and we've cobbled together a little bit of support from the province to keep it going in a very piecemeal way. But, yeah, so it's just really disappointing that our state, like our
Yes.
governments don't have it.
And these kind of initiatives, an amazing initiative, and then when it loses its funding, then what is the assumption? Is the assumption that the 100 new medical grads who joined the workforce, are they all not? Like, they're probably the most friendly to this, but are they not because they're not on this list? Like, then we start this problem of, can we keep up? And we need that constant operational investment to be able to keep this information flowing well. Yeah, 100%. Yes.
One more question, thank you. Speaking, kind of tying the two questions there, in terms of, so it's great to hear that it's part of the curriculum now for nurses and physicians and whatnot. For those who have been practicing, this is my question, right? Like where, I don't know what the directive of care is related to learning more about how to have those more sensitive conversations that aren't leading people. So I'm just curious if there's anything.
Like literally all of us, lawyers included, in professional designations have a obligation to do continuing professional development, but we can do whatever we want. And once you're out, and you can never learn a thing again that will help your patients. Like, so, and I don't know what to do about that.
No, that's probably the biggest barrier.
It really is kind of, yeah. Do you have a question?
Just one general question. What happens when someone needs abortion but might not be able to consent to getting it or not getting it? Like children and people with cognitive disabilities.
Yeah. We treat it the same as any healthcare. So how does that person consent to the flu shot? Okay. What is the process? Do they have, maybe it's a person, if it's a kid, a parent or a guardian who they do trust, maybe it's somebody else, but we would use the same process. There aren't different rules for abortion, which is the key thing about the way things work in Canada, unlike in the States, where I think 35 states require parental consent, and some states require both your mom and dad.
Wow.
Yeah.
Until what age?
Whatever. Yeah, because that's another thing. Here in Canada, we have different ages of majority by province, which does, yeah, that's probably part of it. Maybe it's 21. I didn't even think of that. Mom and dad. I just can't. Kaylee.
I just wonder, I think sometimes law students in particular, we think like, oh, well, maybe the law can make it better. Also, like, the law can also make it worse. And I just wonder if there are, like, particular, like what you see on the horizon in terms of like particular legal reforms that would be like beneficial to expanding access to abortion care.
We're getting down, like things that would be good we're getting down to those sort of minutia. So like the legislation for midwifery in Nova Scotia differs from the legislation in New Brunswick. And we have to change the legislation so that midwives can do abortion care. So like it's that kind of thing. All of those little, like the marginal, what can we expand in terms of scope? There could be like some big picture things, like should mifepristone be an over-the-counter medication? So lots of people think it should. It's kind of that. We're very, of course, when Roe fell, there was a lot of talk about like, should we have an abortion law now that guarantees your right to abortion? And all of us in the movement said like, no, thank you. No, please, because that will just have limitations. It always does. Like France, yeah, they have it in the Constitution. To 16 weeks and 16 weeks only. There's always going to be limits when you create a law around something. So it's more those little, I don't want to call them minutia, they're not, but like those little bits. You know what I mean, Kaylee? Yeah. And Louise.
This is a medical question. But is there a limit to the number of weeks which maybe is beneficial? Or is there
Very useful. Thank you for asking that. So MIFI is approved by Health Canada to 9 weeks. The SOGC recommends 10, gestation. MIFI is used at every gestation. We use MIFI when we know the baby is going to be born still, and we use MIFI, it improves the labor experience. We use MIFI at every, MIFI would work if we sent you home with it, but we're not sending you home at 20 weeks with MIFI. We're not doing that. So that's more what it is. The drug is effective. The drug is being now tried as a daily contraceptive. The drug is amazing, but there are just what's a appropriate way to approve it for use for home outpatient prescription. And that's why we have this 9-10 week. Now, efficacy does change, right? So when you take mifepristone in that 6 to 9 week zone, it is 99% effective. If you take it before, if you take it after, we start getting into the 97 range. So that's 3 in 100 times. You're gonna have to come back. We're gonna have to get more medication. We might have to do a D&C. So that's also part of it, that we want to use it clinically. We want you to have a really good experience. And if you're outside of that window, then we want you to have a really good experience that looks like this. Thank you. You had another question. Sorry, yes.
What's the status of like ongoing care, in particular, migrant people who have like other barriers to help, like socioeconomic status, things like that? Like if you're being prescribed mifepristone, are you also being referred to like, is there a pathway for people to get support with what they need as well, like outside of that?
Not necessarily. So that would really depend on the provider. And this is, again, this question between democratization of access or, I don't want to say quality, but like specialization of access. So if you call the Rose Clinic has a counselor on staff, you're going to get whatever, you can talk to her once a week for a year if you want. If you go to a provider who's fitting you in at the end of their clinic day in Yarmouth at the walk-in clinic, you are not getting follow-up care, right? It's not happening. So but you are going to get the abortion. So it really just depends on what the model of care is. Because we have democratized this, it could be anything. Any person who can prescribe this medication. And as professionals, we just do whatever we kind of want to do in terms of our model of care. I'm going to let Sheila and then back to you, Anne-Louise. Yeah.
Sorry, just quick. I know you're near the end of your time. Many of us are familiar with your work relating to healthcare needs and prisons and jails, which you haven't addressed here. But if you were to just leave us with a top 3, say, priorities around inequitable access now in Canada. I mean, I imagine that's possibly one of them, but what might you, what's your response there?
Yeah, in the book, I kind of really give a priority to Indigenous patients who we have to reckon with all of the reproductive coercion that has happened in the genocidal Canadian legacy ongoing, and figure that out and do better. So that's thing 1. And that's about how we do it, like the way we talk to people. It's, having, for instance, contraception is a part of abortion care. You have your abortion and we say, what would you like for contraception? And even just changing the conversation to be like, would you like to talk with me about contraception? No? Okay. Right, so it's these learning a different way of communicating.
But it's how we do it, but also who is the we?
Yeah.
Who are the
And of course, like making sure that we have Indigenous doulas to accompany people. Like there's so many pieces. For prisoners, we have this situation, I've done this analysis, like looking at the distance between some of our prisons, which can be extremely remote, and procedural abortion. Because thinking about this, medication abortion in a prison setting is extremely disgusting, right? Like you don't have water, you don't have a hot water bottle, you don't have OTC meds, you don't have a companion, you are under surveillance. Like this is crazy to do that. But access to procedural abortion is extremely expensive and can be very, very far. 700 kilometers to the nearest procedural abortion provider from some of our prisons designated for women. So really thinking, as I always am, about like what on earth are we doing incarcerating pregnant people when there are so many dire consequences. And then, you know, one of the things that we have done nothing about is people with disabilities and how we adjust our care. We have nothing. We've done nothing. No research, nothing. It's like a big zero. We have so much work to do, we don't even know what to do, where to start. So those are my top 3. And Louise?
I was in relation to your last question. So say a doctor in Yarmouth, at the end of the day, whatever, is here, can that patient or that individual, or even the doctor refer, hey, you can still call the clinic, the Rose Clinic?
Yes.
And access their resources?
You can always call the Rose Clinic. You can call the Rose Clinic because somebody who has nothing to do with the Rose Clinic prescribed you medication abortion. You absolutely can. It is the...
As far as advertising or promotion.
Exactly.
Is to, you know, let those community physicians and
Yeah.
midwives and that know that that is available as well.
And let 811 know. And like, yeah, it's a lot of communication. 100%. Last word, I think we're good.
Just before I invite everyone to thank Martha again for the presentation, I just want to do a quick plug for the rest of our seminars this term. They kind of come in quick succession. So we have 2 more, one next Friday, and then on November 7th. Next week we have Professor Rujin Habibi, who's joining us from the University of Ottawa. Her talk is entitled Making the Technical Political, the Long Road to the Pandemic Agreement. So a talk very much focused on equity at the global level around in response to pandemics and so on. With that plug for next week in mind, please join me in thanking Martha again. If you didn't see them on the way in, her books are outside.